Please be aware that this episode discusses sensitive topics that some listeners may find distressing. If you or someone you know has been affected by any of these issues, please refer to the help and resources listed in the show notes for details of organisations that can provide support. Welcome to Mindful Merseyside, the podcast series which aims to improve everyone's physical and mental health in the Liverpool City region and beyond. This episode is all about the importance of suicide and self-harm prevention in the community. Now, the people that are on this episode come at it from a wide range of opinions. There are some people with lived experience of suicide attempts and somebody bereaved by suicide themselves. Now, it's obviously a difficult topic, but also a really important one. And we talk about the services that are available, where the shortfalls are coming. We go into why the menopause can play such a big part in suicidal crisis for women and why that hasn't been associated with the risk of suicide traditionally, and the importance of having these services available that are specifically aimed at men. Let's get into the episode. This episode is called Everybody's Business, Suicide Prevention in the Community. And I'm joined by quite a lot of very interesting and different people for this episode. So first up, Dr. Pooja Saini, who's an academic specialising in suicide and self-harm research in the community. Jane Boland, who's clinical lead at James Place, which is a community-based suicide prevention service for men in suicidal crisis. Angela Samata also joins us, who's been personally affected by suicide and who made a BAFTA-nominated documentary called Life After Suicide. Jake Mills, CEO of Hub of Hope and Chasing the Stigma, who has lived experience of a suicide attempt. And joining us remotely, Dr. Louise Newson, a GP who specialises in menopause, and you may have seen her on Good Morning Britain. Thank you all for being here. I think I'd like to start by asking you all individually why you wanted to be part of this project and why it was important to you. So Pooja, let's start with you.
Hi, I've been involved in suicide prevention now for 18 years, and I think over the years I've really seen the importance of involving everybody from across the community, whether that's staff, health professionals, academics or people with lived experience, and how actually the involvement and collaboration of everyone together produces much better services for people who may find themselves in a crisis.
And Jane, how about you?
Yeah, I would really echo what Dr. Saini says. You know, everybody is affected by suicide. I've been working in the field for 20 odd years myself. And once people know the job that I do, they will then almost certainly tell me about somebody that they know, somebody that they love, who has either tried to kill themselves, who's died by suicide. So if it affects everybody, then we need to involve and enrol everybody into finding the solutions.
Yeah, absolutely. And Angela, what made you want to get involved in this project?
Well, I think for me, I had the great privilege of working with Jake at the beginning of the Hub of Hope. I've had the great privilege of working with Dr. Saini and Jane Boland at the beginning of James's Place. And for me, it's about bringing that voice of lived experience. You know, how do we support those bereaved by suicide? And also for me, for a long time, there was a real gulf between the work in suicide prevention and the work of suicide postvention. And now we know that the two things are inextricably linked. How we support people bereaved by suicide has an effect on people who may be feeling suicidal as a result of their bereavement. So for me, it's absolutely fundamental that we collaboratively co-design our services, our podcasts, our media output with those with lived experience. So I'm delighted to be here.
And how about you, Jake?
Yeah, you know, I've spent probably the last 10 years speaking about lived experience, and I think it's probably the one thing that I'm always going to continue to do, because I think it's the one thing that I'm noticing has paved the way for everything that I'm doing now and what so many other people are doing. I think the people that we've got involved in this project is, you know, a huge wealth of experience from so many different angles. And I think I'm really actually delighted to be the token male in the room as well.
In a room full of fabulous women. Speaking of which, Louise, what made this project important for you to be involved in?
Well, it's so important because the psychological impact of the perimenopause and menopause has been neglected for decades, in fact, centuries. And it wasn't until I opened my clinic 7 years ago that I started to hear stories of women who have had suicidal thoughts, often very intrusive, very dark thoughts, and it's related to their hormones. But no research has really been done in it, which is absolutely terrible. So connecting with Pooja and their amazing team is really going to shape future for women, I hope, and men, of course, who are indirectly affected by the menopause and perimenopause.
Now, Pooja, why do you think it's important to have services available for people in crisis within community settings?
Well, I think one of the NHS targets is to try and reduce people coming into hospital, into A&Es. And one way to do that is to have, the right services and accessible services within community settings. Also, I think people who do end up in hospital, it can be really negative for their long-term outcomes. So if we can avoid that, then I think that's really key. But I think one thing to say is to have services in a community that have rapid access. As soon as someone voices that they're in crisis, there should be something available for them and they shouldn't be put on waiting lists. And that's what we're trying to work towards.
And how far away are we from that at the minute?
I think we're making some headway with men, with the fabulous service that's now open for James Place, Liverpool. We've also got a lot of services within the voluntary sector, but they're not necessarily providing clinical therapeutic interventions. So I think we need more services that are kind of not in the medical setting, but in a community setting.
Yeah. And Jane, why is it important to have these services available specifically for men? And maybe, Jake, you could chip in here as well.
Yeah, I mean, in terms of men, we know this, the data, of the 6,000 people who died by suicide in sort of the UK last year, 3/4 of those were men. We know that there are occasions when we need to target an approach to a specific group of people related to a specific condition. And I think a suicidal crisis is clearly evidently, and I'm saying evidently because I think we're building an evidence base at James's Place that is showing that what we do is help, by offering that sort of urgent support, clinical interventions, talking therapies to men at the time of their suicidal crisis, that we're making a massive difference in the lives of those men. A suicidal crisis is very different from a mental health crisis.
Yeah.
And a significant number of people who die by suicide are maybe having some contact with health professionals, but it will usually be a GP, and they will usually be talking about not feeling great and feeling low. But the crisis is almost always triggered by like those kind of everyday events, that a person is finding themselves overwhelmed by debt, relationship breakdown, and it's having that really specific response. I've worked in mental health services for a long time, and I know that there are people still doing amazing work in those teams. But it's really hard to imagine how you can, deliver a service to 5 different people in one day. One person who may be having a psychotic breakdown, one person who's in a suicidal crisis, one person who's maybe a perimenopausal woman whose suicidal crisis is completely different. So I think it's really vital that we think about delivering services at a place that people need them and targeted to the needs of that individual person, especially around suicide. These are people who are at risk of death.
Yeah. And I mean, it sounds like a bit of a cliche, and maybe you could answer this one, Jake. Are we still in a position where men are finding it harder than women to reach out for that help?
I think there's a big myth that men don't want to talk. I think men do want to talk. But one of the biggest problems that we have is creating an environment of understanding for men to feel comfortable enough to talk. And that's why I think when we look at the community transformation model and try and support that preventative support within a community is absolutely vital for creating those safe environments for men, particularly if we're looking at non-clinical environments as well, to engage people into services without really them feeling like they're being engaged into services as well. The point that Jane makes there is absolutely vital, of that the amount of people, not just men, but the amount of people who die by suicide every year without being known to secondary mental health services is almost 3/4 of people who take their own lives. So there's quite a big difference there between people recognising they need help and support at an early stage enough to then go and get that help and support. So if we were trying to engage alternative methods of reaching that help and support, whether that is through voluntary sector, whether it is NHS working alongside the voluntary sector instead of seeing the two as completely separate and rivals, then we can try and create environments of understanding. What's absolutely crucial, I don't think anyone would disagree, we don't want people going and relying on NHS services to stay well in their communities. So obviously we have that as one of the options, as one of the support mechanisms that you can have, but it's about staying well after you've received that help and support. So there has to be that community asset and many community assets for people to be able to access.
Yeah. Now, Jane, you mentioned before we started recording that you've been asked a few times why there isn't a James's Place for women. Why is that?
Well, there isn't a James's Place for women because we set our service up for men. Increasingly, when I'm asked about it, and increasingly when I hear about sort of the work of Louise and some of the research that's come out with Pooja, that I know that if there is an organisation out there, or if there is a sort of a plan to have a service that targets women in a suicidal crisis, it has to be sort of a multidisciplinary approach that includes a medical intervention that will be looking at women's hormones. It's unthinkable now to think that it couldn't be. So for men, it feels like it's pretty cut and dried, the men we see. It's a psychosocial crisis. It's a response to a set of sort of social circumstances that feel overwhelming. Whereas I think that might be happening in women, but then there's something much more complex going on biologically. And anybody, as I have, who's worked with women who have had like a postnatal psychosis presentation, there is no way that you can see somebody that poorly 5 days after being as right as rain and not understand the impact that hormones can have on a woman's mental health.
I'm guessing you agree with that, Louise.
I totally agree. I couldn't agree more. And wouldn't it be great if we had James's Place, not just in Liverpool, but all over for these poor women? Because often what we see in the clinic was that once people are under mental health teams, hormones are just completely forgotten. And it's completely wrong. We need to have this joined up approach. We've got a psychiatrist, Louisa Lovett, who's going to work with us soon in the clinic. So I think we'll probably be the first menopause clinic where we have a psychiatrist here with us. But with this joined up care for women is so important.
And Angela, having been bereaved by suicide and the work that you've done since then, kind of what are the important things that you've learned from your journey so far that you could share with anyone listening?
I think for me, you know, I've spent 20 years talking about my bereavement, and what I still find surprising is that there are so many of us. You know, it's very, very rare for me to walk into a room and, you know, people naturally say, you know, what do you do? Or they've seen something that I've done on television, or, you know, a podcast like this or whatever. And I think for me, it's really, every time I do something, every time I use my voice, it's about helping one person. You know, if one person realises that they're not alone with this, if one person realises that there are lots of people like us, we're everywhere. You know, I was having a conversation recently with somebody saying, you know, oh yeah, but the bereaved, you know, we don't talk like that in front of people who are bereaved by suicide. You know, we only talk like that internally when we were having a discussion about language and suicide. And I had to remind them that people who are bereaved by suicide are everywhere. They're within our police forces, our fire services, our universities. You know, people affected, impacted by suicide and bereaved by suicide are everywhere, because we do have 6,000 deaths by suicide a year. And I think for me, you know, it's always a great privilege, because I can't tell you the number of bathrooms I've been in where somebody has said to me, you know, I've never told anybody this, but, you know, and a woman will tell you about her bereavement and her loss, but she's never, you know, talked about it to anybody else before, you know, and that's happened everywhere. So for me, it's about being open and honest. And I think that by having those bereavement services, suicide prevention services within our communities, it recognises that we're everywhere. It recognises that we don't want to have to travel miles out of town to go to special places.
Yeah.
Because what we need is to be able to have our services like James's Place, like the Hub of Hope. We need to empower people to reach out for support themselves. So why does it have to be miles away? Why does it have to be in a clinical setting where you've got a waiting list? You know, why can you not just have the Hub of Hope in the palm of your hand, on your phone, free access, anytime, 24 hours a day, no waiting list at James's Place? You know, why can't that be what we can offer to everybody? So it would be wonderful to have that utopia. I don't think we're quite there yet, but we're definitely doing our best to try and make those services available.
Now, Louise, there is a national statistic that says women between 45 and 49 have been known to be at a higher risk of suicide for many years. And obviously, those are women who are of a menopausal age. Why do you think that it's never been associated with suicide before?
I think it's lots of reasons, but one of them is that the menopause is always defined as periods. So to define someone who's been menopausal, they can't have periods for at least a year, or perimenopausal, periods are changing, or it's defined as loss of fertility. But actually what we do know is that our hormones, estrogen, progesterone and testosterone, are really important in our brains. They're neurotransmitters, and in fact our brain produces these hormones. It's not just about our ovaries. And so we've forgotten basic science, actually. We also, as you all know, is that our brains like homeostasis. They like everything to be stable. So whether it's our blood sugar, what we're eating, what we're drinking, whether we're sleeping enough, but also when we have changes in our hormones, these fluctuations will trigger a response in our brains. And for some women, it's absolutely catastrophic. And it's thought that it's the perimenopause, when these hormone levels are fluctuating a lot, is worse actually than the menopause, when hormone levels are low and remain low. So we've not even really been thinking about the perimenopause for many years. But if you look back in the history of time, you know, the Greek word for womb was hyster. And if you think of hysterectomy and hysteria, they're obviously so closely linked. We've known for many years that people have been suppressed by various amphetamine-based medications or benzodiazepines to try and quieten middle-aged women. But this is all related to hormones, but we've just ignored it. And so actually knowing that hormones are safe, knowing that they can improve mental health and hopefully reduce suicidal thoughts is really important. And we see it in our clinical practice every day, but it's just really important to take it further and show others how important hormones are.
And do you think that health professionals consider hormones when women over 40 come to them with mental health issues? Because you do hear horror stories, don't you, of women who are clearly perimenopausal, who get kind of palmed off with antidepressants, or they're not really listened to or heard.
It's happening all the time. Medical gaslighting with the menopause is huge, very sadly. But we know about 1 in 30 women, at least probably under the age of 40, have an early menopause. So there are women in their 20s and 30s who will be perimenopausal. So we don't have to wait for older women. But we have to think about reproductive depression. So women who have PMS or the more severe form PMDD, women who have postnatal depression are very likely to respond more adversely in a psychological way in the perimenopause and menopause, because there are hormonal changes in these times of lives as well. So if someone is having these symptoms, we have to be thinking about hormones. I spoke to a lady yesterday who's still in a psychiatric hospital. She's had 2 suicide attempts, but she's 47 now. She tells me that when she was a teenager, she used to get very deep, dark thoughts, often very intrusive, suicidal thoughts. She's had 6 pregnancies, 3 episodes of postnatal depression, and now she's had 2 suicide attempts. And her periods have changed over the last 2 years in line with her crippling anxiety and worsening of these thoughts. She's on antidepressants, she's on quetiapine, she's been started on lithium, and they're talking about ECT. Thankfully, I spoke to the psychiatrist this morning who is going to prescribe her hormones. I don't know why we can't be thinking about hormones as a treatment to improve people's mental state.
I mean, it's crazy that all of those things have been prescribed or considered, especially ECT, before hormones, given her age and her past experience as well.
Yeah, I'd like to say she's an isolated case, but sadly we hear it all the time. The number of women I've seen in my clinic over the last 5 years who've had ECT is just too shocking to even recount, actually, with no mention of hormones. And I'm not here saying that every single low mood is due to hormones, but women are allowed to have two pathologies as well. You know, we are allowed to have other diseases as well as being menopausal, but we should be thinking about the obvious things first as well.
Yeah, absolutely. Now, Jake, from your experience, do you think enough is being done in the community to help people who might find themselves in a crisis?
The short answer is no. The longer answer is that I think we've come a long way in a relatively short amount of time recently.
Mm-hmm.
But I genuinely believe that the onus of that change has been on those more often than not who have their own lived experience, who see the gap, see the void, have experienced the void, and have then in turn created something from a place of hurt or loss or pain, despite maybe having no funding, without having any of the mechanisms to really know exactly how to do things and how to make that change, but being driven by that personal passion and drive. And I think that there's an awful lot that we could be doing to help support those within the community who are creating those life-saving organisations like James's Place, like so many of other organisations that often have the trust of people, who often will create these environments where people feel they can walk in, they can be themselves, they can see other people who maybe look, sound, act, describe experiences similar to their own. So I think we've come a long way in a relatively short amount of time, where a lot more people have felt able to create something themselves. But I think we're a long way away from those organisations, those people being supported properly by the system. And I think that's one of the things that I would repeat what I said earlier. I think we should be working a lot more closely as a collaborative across statutory services and across voluntary sector services and even private services as well, to not see each other as rivals, not see each other as one or the other, but to say, how do we complement each other's services? How do we work alongside? How do we refer internally, externally? How do we make sure that once you're seen by one service or you're discharged, that you can then go into another? So I think there's a long way to go, but I think we're really particularly good at that in Liverpool as well. I think there's a lot of examples and positive examples in Liverpool, and maybe that's a bit of a, get up and show them regardless attitude that we often have. But yeah, I think there's a positive there, but there's a long way to go as well.
I think, Angela, you mentioned before people coming up to you in toilets, after you'd spoken. Mm-hmm. And I think there's something quite beautiful in you being vulnerable, and it allows people to be vulnerable back to you. Mm-hmm. I was wondering, Jake, obviously you've been extremely open about your experiences, and that must have helped a lot of people. Was that a hard decision to make, to be so open? Because I would imagine that going through what you went through, your initial thing is to keep it quite private, and lots of people do, and obviously that's fine, but was it difficult for you to decide to be so open?
I think the majority of it is down to timing. I think at that time when I decided to speak publicly about it, I'm not going to downplay how difficult it was, and even still now, you're still quite open, but you're still really vulnerable every time that you do speak about something personal. But as soon as I did speak publicly, and the amount, as Angela said, the amount of people who came to me saying, "You've just described exactly how I feel, you've just described exactly what I've gone through. I thought I was the only one." There was a lot of comfort that came in other people saying, I'm going through this as well. So, yeah, as I said, if it was a couple of months before, it probably would have been a lot more difficult, but it was just timing felt right, and the response that I got from that was what has driven me to continue to do that.
And would you agree with that, Angela?
Oh, absolutely. I mean, the reasons why lots of those conversations happen in bathrooms is because people will often feel like that's a private space where they can share things with you. But I think for me, some of the most important innovations that have happened recently have been around challenging the stereotypes. Men don't talk. Yes, they do. I've yet to meet a man that didn't want to have a conversation once they realise about my lived experience. So many people, so many men want to talk about it. So that's the first one. The second one is exactly as Louise just mentioned, around hormones being belittled, the effect of hormone imbalance being belittled, hysterical women. And I think that, challenging all of those stereotypes, thinking about female suicide, it hasn't been thought about for a long time. Lots and lots of stereotypes. And I think the research that's coming out now, the research that's coming out of John Moores University, the research that's been done at James's Place, for instance, with men who are actively suicidal, this is not anecdotal. This is good, robust academic evidence that together with the lived experience of being bereaved by suicide or feeling suicidal, that is such a vital combination. They are the pillars that we stand on because we have the evidence base now, we have the lived experience, and bringing those things together is a game changer, because it's very difficult to argue with a really robust academic evidence base. And within Parliament, I sit on the all-party parliamentary group for suicide prevention. And the thing that made the biggest difference with that parliamentary group to the policies was the evidence base that is coming out and also having lived experience in the room, and it makes such a vital difference to all of the work that we're all doing around suicide prevention. And I think that it's very, very difficult to argue with any of that when policies, procedures are being created, but we just need more of it. We need more.
Louise, I'd be interested to know, because obviously the menopause isn't just an issue for women, because there are men who need to educate themselves more, let's be honest, on things to do with the menopause, because, men have got wives, they've got sisters, daughters, friends, and every woman will go through the menopause at some point. They will obviously be affected to differing degrees by it, but they will go through it. And I'd just be interested to know if you are a woman or friends with a woman or a partner of a woman who has gone to her GP and not felt heard, because it is difficult, I think, if you aren't medical, you walk into a GP surgery or into a hospital and you almost feel like you're handing your power over because you think, I don't know as much as you, so you must be right. But if you're in that experience and you've left and thought, I don't feel like I've got the answers I needed, or you've referred me to this, or you've prescribed this and it hasn't helped, how do you, not argue, but how do you go back and challenge that, Louise? What advice would you give?
Yeah, you're absolutely right. Being empowered as a patient or a patient's advocate is really crucial. And for many years, I've also worked as a medical writer. So we've developed the free Balance app and website where there's a huge amount of information. And this is really making a difference, I think, to people, because when you have the right information, you can talk quite differently to your healthcare professional. And I really often advise people to speak to the healthcare professional in not a confrontational way, because no one wants to fall out with their clinician, but say, is there a reason that you're not giving me evidence-based treatment? Is there a reason that you're denying me a treatment that I know has more benefits and risks? And actually, as a consenting adult, I would like to try this treatment. Then it's quite hard for somebody to say, well, no, I'm not giving it to you because I'm a bit worried about perceived risks or whatever. And it's really sad, especially when I hear, young women who are really struggling and being offered these other drugs as an alternative, or just being turned away to buy a relaxation tape. But it's also very difficult for a lot of perimenopausal and menopausal women, because sometimes symptoms come on quite gradually and it's very easy to put them down to other circumstances. Maybe there's been a bereavement, maybe there's been a change in job, maybe there's been difficult, stressful circumstances at home. But actually, if you ask women, they often know. If you say, do you think any of these symptoms could be related to your hormones? And if they say yes, then the next question has to be, why are you not taking some replacement hormones? And we don't have to wait for periods to stop. And even women who have PMS and PMDD, we sometimes just give hormones for the few days where they're experiencing symptoms. And we can give treatment as a therapeutic trial. That's all people do with other medications like painkillers and antidepressants. Same with hormones, we can try them. They're very, very safe. They're just the same as our natural hormones, and see the response and allow women to tell us whether they feel better or not.
So I guess it's about doing some reading or some listening and going in armed with that information to empower and advocate for yourself, isn't it?
Absolutely. And that's really important. But also, as a patient, you are allowed to have a second opinion. I don't mind at all if someone goes and has another opinion from someone else. And in fact, it's fine. It's always good. So nobody should feel that one doctor or that one clinician, they can't speak to someone else. But sometimes it takes somebody else to go with you to maybe be your advocate. And that's fine. And I think it's important, especially when we're talking about mental health, because a lot of people have feelings of very low self-worth, low self-esteem, low confidence. And so if you make this appointment with somebody, you think it's going to really help, and then you feel beaten down because it's not worked, you've got to allow someone to help you pick up and keep going, because the menopause affects people forever once they're menopausal. So a lot of women, it will be 30, 40 years. Younger women, it will be even longer. So it's not just a few days or a few years. We have to be having the right treatment to invest in our future health.
Yeah, absolutely. And Jane, if there are men who are listening, who are resonating with this and feel like they need help, or if they know somebody that does, how can they access your services? How does it work?
Yeah, so we now have James's Places. That's a bit of a mouthful, isn't it? We now have James's Places in Liverpool and London, and men can access our service themselves. They can self-refer through a form on our website, or their friends and families can do it. Or if they talk to their GPs, or in Liverpool and in London, we've done work with local GPs so that they know about us. And we've also done a lot of work with sort of local A&E departments and those sort of services, so that they know that we're here as well. So if you're lucky enough to live in Liverpool or London, you can access a service. We're just about to open our third service in Newcastle, and men in Newcastle will be able to get to us. But that's what we've always tried to do, is we've tried to make accessing our help as straightforward as possible. So we've always let men self-refer. We've always had what we've called friends and family referrals, which sounds a bit of an odd thing, but it does mean that your mum can do it, or your sister can do it, or your missus can do it.
And how many of those do you get where people aren't referring themselves? It's somebody who's worried about somebody else?
About a fifth of our referrals will be from family members. I know that because we just went through our stats this morning in a meeting, so I came armed with that. But yeah, about a fifth. And it depends on the centres. So I think Newcastle will be a bit slower to because it is just starting, but sort of certainly in London and in Liverpool.
And your sessions are still free, Jane?
Yeah. So our service is free for men who need us. It's done, our sessions take place in our lovely centres in Liverpool and London. We work with men who are just in a suicidal crisis. So we just do the one thing, which I think is what makes it relatively straightforward for us not to have a waiting list and not to keep men waiting for our service. We've never had to have a man wait more than sort of 2 working days to be seen.
Oh, that's amazing.
By one of us. And that's in 5 years, just over 5 years that we've been operating.
That's wonderful. And other than that, what other services can people access if they're listening to this, whether it's for themselves or somebody else? If somebody is in need of these services, where can we point them to?
For most people, it will be their GP who is that sort of first port of call. And most people who are struggling with their mental health, the support that their GP can both provide and can offer will be all that's needed. Most people who have depression, anxiety, that the help will come from their GP. It's antidepressants are effective medication. Talking therapy is effective and really helpful. It's only a few people who go on to need that sort of extra secondary care, or who need to come to services like us. Most, I just want to reassure people that the help is there. It's not a terror. We sometimes forget how effective the NHS is at providing support for, I look at the stats to do with IAPT services and stuff, and they get something like 80,000 referrals a day. And those people get seen, over 1 million people a year are seen by IAPT services. It's amazing. And the vast majority of those people will experience a really, really positive service and will feel loads better. Most people don't need services like James's Place.
And what about nationally? Because obviously there are issues with GPs waiting at the minute. And if somebody is in a crisis and they're not in a mental place to be able to go, I'm going to set an alarm for 8 o'clock and then I'm going to phone 59 times until I get through to the GP, where can we point those people to?
So we've also got NHS crisis lines now that are readily available, and we've actually done some evaluation of that work and seen how effective they can be. One thing that's really interesting that I think resonates with what you've been talking about today is a lot of the calls are to do with social issues, but it does work well for signposting, whether it's signposting people to community services that are really useful or asking them to come in to A&E and actually speaking to them along the way. And obviously there's Samaritans as well, which I'm sure many people are aware of. So there are other services that are being brought into good use from the NHS as well as the third sector. But I think what Jake said before about services working together and knowing of each other, that's really important in this line of work. And I just wanted to highlight as well that because of the work I'm doing with James Place, I've had many people contact me about young people or women. So I think it's just highlighting that we do need services for different population groups within the community settings. And a lot of people who talk about their crisis in adulthood talk about it starting at school age. So a lot of the work we're now doing is focusing on, okay, how can we try and help some young people who get into crisis? And hopefully that won't continue into adulthood as well.
So all of the services that you've just mentioned will be in the show notes. So if anybody's listening and they haven't managed to write down or they don't have a number, just look in the show notes to this episode and all that information will be there for you.
And also the Hub of Hope is free. And it's something that you can just download on your phone. You can be carrying around with you. And I think, Jake, have you got 12,500 different services on there now? Have you just topped 13,000 or something?
Yeah. So for anybody who doesn't know, the Hub of Hope is a single directory for mental health services. So
Right.
it's a free app, it's a website. And yes, it's got just over 13,000 services on there nationally. That is local groups, that is national support as well. It's for all people, all ages, all genders. It's for as many different organisations as possible. So whether that's NHS support, whether that is organisations like the crisis lines are on there, Samaritans, local groups, and even to take Jane's point, but even one further, that a lot of people might not even want and need to go to a GP. It might just be that they just need to be around other people who are going through similar things. So we have those support networks on there for anybody. So yeah, have the Hub of Hope, download it. It's free to use, free to be on.
Thank you so much, everyone, for joining us. I think it's been a really interesting but also a really important chat that we've just had. So thank you very much.
Thank you.
Thank you.
You've been listening to Mindful Merseyside, brought to you by the Institute for Health Research at Liverpool John Moores University and produced by Inabella Media. We hope you found the conversation informative and insightful. If you or someone you know has been affected by any of the issues discussed in this episode, please refer to the help and resources listed in the show notes for details of organisations that can provide support. I've been your host, Gemma Cutting, and don't forget to subscribe to Mindful Merseyside wherever you get your podcasts. Thanks again for listening, and I hope you'll join us again soon.